And more very often, I tend to think that I should go through this chapter because I have to be thoroughly acquainted, thoroughly conversant with this disorder. But I don't get time because of our, you know, patient load, work burden, and also at the same time, the core elements of rheumatology, uh, are also quite vast, and they are continuously changing. So we have to keep up with them. So I can't pay attention to the non-core, that is peripheral elements of rheumatology. For example, this diffuse parenchymal lung disease associated with rheumatic diseases. So I had great interest, and that's why when Dr. Ehsanujaman approached me to to participate in this session, I agreed with, I should say, great happiness, great pleasure, or rather I can say with great ecstasy. And when I learned that, Professor DJ Christopher will be speaking, I have very good impression about the teachers of Christian Medical College in Vellore. They are very competent, highly knowledgeable, and so I got, very much ecstatic that, without much, labor, I shall be learning about this DPLD, one of my long cherished topics. So now, actually, about Professor DJ Christopher, Dr. Ehsanujaman Manna has told something, and I think, actually, about DJ Christopher, we can say many things, but simply that will occupy, or that will squeeze his time for talking. So I am not going into the details of, of the credentials of DJ Christopher. I rather invite DJ Christopher to start giving his talk, please.
Thank you, Professor Atikul Haq. Uh, Good evening to all of you. It's a pleasure to meet you on this virtual platform. We are linked by the fact that our countries are friendly nations. We have historical connections. And more importantly, my institution, Christian Medical College, Vellore, is a favorite place for some of your patients. So almost every outpatient day, we would see at least one patient from Bangladesh. So that is the connection we have, and we see your prescriptions, and we appreciate your feedback and notes, and it helps a great deal in us making our diagnosis. And I hope in turn the advice we give also helps you to manage the patients when they come back home. So it really gives me great pleasure to have been invited by Dr. E. Hassan and team. I mean, I don't think anybody will envy my position, because this is the first lecture I'm giving. I have chaired 2 sessions, and this is the most difficult area for even pulmonary physicians, leave alone general physicians and others. It is quite difficult even for us, but I'm sure you will find it even more difficult to even understand what this is. So I have a very challenging job to try and make you understand. Many of you are not respiratory physicians, and you come from other specialties and probably general medicine and maybe even general practice. So it is a challenge. I will try to do what I can. I really wish I had an easier topic, at least the first time around, but I will do what I can. And Professor Atihul Haq is a good friend of Dr. Debashish Danda, who is my close friend, and he has told me a lot about him. It's a pleasure to share this podium along with him. Okay, let's dive deep into this topic. Interstitial lung disease, people often call it ILD for short, is also called diffuse parenchymal lung disease, DPLD. So don't get lost in these short forms. If you are used to saying ILD, just keep saying that. That is good enough. It is defined as diffuse parenchymal diseases, obviously of the lung, which are of heterogeneous distinct lung disorders classified on the grounds of shared clinical, radiographic, physiologic, or pathologic factors. So we have to understand this definition. They are a group of heterogeneous disorders. ILD or interstitial lung disease is not one disease. It is a group of disorders, and in fact, the definition says they are distinctive lung disorders. Each one has its own uh, type of presentation, response to treatment, and so on and so forth. But they are classified together because they have shared clinical, radiologic, physiologic, and pathologic factors. So this is the classification of DPLD or ILD. So if you see here, you have, let me change the pointer. Just give me a moment so that I can change my pointer.
But your screen has not been shared.
Oh, so sorry. I am so sorry. I thought I shared my screen. Okay, so this is the definition I gave you. So I think I explained this to you. So hopefully you're caught on. It's a group of heterogeneous disorders, but they share clinical, radiographic, pathologic factors. Now let me get my pointer. Okay. So this is the classification. So ILD or DPLD is divided into DPLD of known cause. So such as drugs, rheumatic diseases. Dr. Atihul Haq was talking about it. A lot of rheumatological diseases present with lung manifestation. So we know the cause. The second category, which is by and far the most enigmatic and challenging, is the idiopathic interstitial pneumonias. As the term suggests, idiopathic means we do not have a known cause, and therefore this will be a diagnosis of exclusion. Then we have granulomatous disorders, example sarcoidosis. Granulomatous because if you biopsy the appropriate tissue, you would see granulomas. And there are other disorders like LAM, PLCH, and so on. For today, we will forget about them. We have enough of our plates looking at all these things. To this also, I want to add among the known causes will also be pneumoconiosis, that is occupational lung disorders. They also come in this category. So among these, so let us come to this one. I was telling you that this is the more enigmatic one, idiopathic interstitial pneumonia. Of this, idiopathic pulmonary fibrosis is the most important. It is the prototype. When we describe interstitial lung disease, we will describe idiopathic pulmonary fibrosis. And then we will say the other things are different in the following ways. So often when we say ILD, we are talking about this. Okay. So I am not going to spend too much time on that. Symptoms. Dyspnea and exertion is the most common symptom, usually months or even years. Dry cough. Many patients are, by the time they are diagnosed, have been treated for bronchitis, have been treated for asthma, heart failure. And the idiopathic pulmonary fibrosis, I was saying this is the prototype, is common in the 5th and 6th decade. So in slightly older people and with a male preponderance, like many other things. All the bad things happen to men. And it is characterized by bibasal inspiratory crackles. In physical examination, if there's one way we can catch it, it is if you auscultate the bases on both sides, you have very distinct crackles. They are described as Velcro crackles. Velcro is, we have Velcro in shoes, in bags. It makes a crunch kind of sound, that when you open the Velcro. So that's the kind of sound you will hear. So if you hear on both lung bases, you can make a diagnosis of interstitial lung disease or IPF. Clubbing occurs in about 50% in this IPF. Okay. Now, what is very important is a timely and accurate diagnosis. As I was saying, that people are usually treated for many other things. One of the studies showed that 55% of patients reported consulting more than 3 physicians before receiving an IPF diagnosis, which means that if you are aware of this, and if you understand this, you may be able to diagnose some of these things, and maybe you won't be able to manage them well. You may be able to refer them to the appropriate physician. Ideally, a respiratory physician should take care of these patients. Physiologic testing. Now, measurement of lung function is crucial. So, what will happen to lung function? So, in these disorders, the lung shrinks due to fibrosis. So, just if you want to just simply remember, inflammation and fibrosis. That's what is happening in the lung, which means the lung, of course, it will happen in both lungs. For the sake of comparison, I have put a shrunk lung and a normal lung. So the lung becomes like this. And since it is fibrosed, it is difficult to inflate this lung, which means you have to take more breathing effort to open this lung. That's why patients are short of breath. So this kind of disease is called a restrictive disorders. When the lung cannot expand to its full capacity, we call it restrictive disorder. And when we do lung function testing, that's what we will find. The second thing we will find is what is called impaired gas exchange. See, since there is inflammation and fibrosis, when fibrosis happens, this is the part of the lung where the exchange of gases happens. This is the coming into the alveolus. Alveolus is the very end of the long bronchial tree. And so when oxygen comes inside, it is nicely created by God to be very wide and open, having a large surface area. And around it is the vascular structure. You have the arterial and the venous structures all around it with a very thin membrane between them. And it is while the gas comes into this passage that the exchange happens. The blood gives off its carbon dioxide and takes oxygen, and then takes it to the heart and then to the rest of the body. Now, when there is fibrosis in this area between the vessels and the alveolus, that's called the interstitium. The part between the two things is called the interstitium. So that is where fibrosis happens. When that happens, then the diffusion of gases from the alveolus into the vessels becomes difficult. So that's what we mean by impaired gas exchange. It is in fact called alveolar capillary block. This is the alveolus where air comes. This is the vascular capillaries, and that impairment is called alveolar capillary block. Now, rarely, in some disorders, some of the interstitial lung diseases, there is also obstructive disease, which means this is a normal airways where air can go freely in and out. But look at this passage, air cannot go freely. Now, this happens in some interstitial diseases like sarcoidosis, hypersensitivity pneumonitis, and so on. So, because in addition to that fibrosis around, they also have granulomas which are in the airways. And these granulomas block the passage. And so you can get obstructive disorder when you do lung function test. So how does all this happen? We do not know what the stimulus is in some situations. For example, in occupational disease, we know what the stimulus is. It is the occupational dust. There is something called hypersensitivity pneumonitis. That is when people inhale, let us say, pigeon feathers, cotton, and other things. There also we know what is the cause. But in idiopathic pulmonary fibrosis or IPF, and some of the other disorders, we don't know what actually causes this lung injury. Something that we do not know causes the lung injury, and then the lung heals with fibrosis. So when the lung injury happens, it's an inflammatory process, and then when it heals with fibrosis. There certainly is some genetic factor that predisposes people to this lung disease. Again, these factors are not very well understood. Radiology is absolutely crucial when we attempt to diagnose these disorders. Chest X-ray patterns have to be very keenly noted. Now, in most situations, it is the clinical picture, including history and physical examination and radiologic pattern, that will help us to make the diagnosis. We don't have, unlike some of the rheumatologic disorders, we don't have blood tests. We put them together, you know what, is it rheumatoid, is it systemic sclerosis? So we do not know, we do not have those kind of blood biomarkers. So we have to go by these patterns. So in chest X-ray, for example, we have to look at whether there's upper lobe predilection or lower lobe, whether it involves more of the upper lobe or lower lobe. If it is upper lobe, it can be something like sarcoidosis, hypersensitivity pneumonitis. If it is lower lobe, it can be this IPF. The hero for today's talk is going to be IPF. So when we talk about it without putting any specific name, we are talking about ILD of IPF. The second thing we will want to look at is whether there is reticular pattern or alveolar opacities. Okay, I will show you X-rays, then you will understand. And the typical picture of IPF is bilateral reticular opacities. And these are more predominant in the periphery of the lung and in the lower lobes. So this is an X-ray. Now you can see what reticular. Can you see that this X-ray has this kind of fiber kind of thing? This is called reticular pattern. So you can see this. And as I described here, it is more predominant in the lower lobe. See this lower lobe, right, and the left lower lobes, and somewhat spares the upper lobe. And this is a typical pattern of the IPF. And the lower lobe involvement is clear in that you can see the diaphragm is a little obscured. That's because the lower lobe is involved by this fibrosis. This reticular pattern usually means there is fibrosis. Now, CT is really the key imaging modality for us. And in particular, we do what is called high resolution CT scan. And in this, we have typical patterns. We have something called honeycombing, which is somewhat end-stage disease where there's a lot of fibrosis, and ground glassing, which is somewhat early disease where there's alveolar inflammation. When there is inflammation, you have drugs which can work against inflammation. When there is fibrosis, we do not have any, we have very little options. When fibrosis has happened, it is already scar. The options are very limited. So this is the deal. So if we can diagnose it somewhat early when there's ground glass shadows, it is more amenable to treatment. This is the ground glass pattern. Can you see this kind of spotty kind of look all around the lung, both sides? It's a little more pronounced here. This is called ground glass. This is an inflamed lung. This lung, the involvement is in the form of inflammation, and this will be amenable to treatment. Now we go to the UIP pattern, which is the fibrosis pattern in CT scan. So this is a pattern which is not good. The abnormality seen a reticular abnormality. Then there is something called honeycombing with or without traction bronchiectasis, and absence of features listed as inconsistent with UIP. So these are the typical consistent factors. If you have features which are inconsistent with it, then you will think that perhaps it is not UIP pattern. So I want to show you the enlarged form of this, and we can see this. This round things you see here in the lung bases are called honeycombing. Okay, here also honeycombing, basal honeycombing. This is very typical of IPF. or UIP pattern on the CT scan, which usually means it is a IPF. So this is also honeycombing and reticular shadows. Throughout, you can see these kind of shadows. These are all reticular shadows, all reticular shadows. And this is called traction bronchiectasis. The fibrosis around here is pulling the bronchus. So you can see a dilated bronchus here. That is called traction bronchiectasis. So these are patterns which radiologists will call it UIP, which stands for usual interstitial pneumonitis. And then if there is no cause found, we will call it IPF. So this kind of pattern should be there to call it IPF. IPF means there's a lot of fibrosis. Okay. Right. Now, apart from radiology, so it is radiology which is really the key for us. Apart from this, some of the interstitial lung disease, such as sarcoidosis, they will have granulomas in the lung. Some malignancies also can produce diffuse lung disease. So these are situations where a lung biopsy may be, a bronchoscopic lung biopsy may clinch the diagnosis. So this is the bronchoscope. It goes into the lung through the airways to the edge of the lungs, and it takes a biopsy of the lung parenchyma, the lung substance, lung tissue. Now, we can also put fluid inside and then take it out and send it for cultures. We can send it for cytology. So all this can be done with a bronchoscope, but we will do it only when we suspect disorders which have granulomas or malignancy. Okay. So the American Thoracic Society, we'll come back to the IPF, which is no cause found. It is not granuloma. It is not malignancy. It is just fibrosis. So the diagnosis of IPF requires exclusion of known causes. We should have excluded connective tissue disease. We should have excluded drug toxicity. We should have excluded occupational disease. When we exclude everything and then we find that UIP pattern, you remember I showed you that pattern with honeycombing, lot of fibrosis. When that pattern is seen, then you know it is IPF. Okay. Now, there are some situations where you have pattern of UIP and you have pattern of this ground glass shadows and things like that. So there is fibrosis, there is also inflammation. So in these situations, sometimes you may need a surgical biopsy, which means you do an open chest surgery, take pieces of lung and see whether there is just fibrosis or there is also inflammation, because these two are going to be treated very differently. But open lung biopsy is not easy, and not many patients will agree to do it. So easier one these days is what is called VATS biopsy. So what is VATS biopsy? The surgeons use laparoscopic instruments. They go through the chest and then they take pieces of lung like this. And that is easier, better tolerated. And in a difficult case, when you cannot make out based on all the information, radiology, clinical features, then you may resort to this. But this will be done in about less than 5% of the patients. Okay. So this is the algorithm. So first, if you have an ILD, first thing to do is you rule out all the known causes. Is there joint pains? Is there early morning stiffness? Are there skin lesions? Or kidney and the other organs involved? So all this you will go through. Then drug history of exposure, mining, history of exposure to birds, farming with organic dust. All this you will explore. So if none of this is there, you do a CT scan. And then if you see this UIP pattern, which is fibrosis, then you diagnose IPF. So as I was saying that we are primarily going to talk about IPF today. If not, then it becomes complicated and sometimes you have to do biopsy. Now, often what we need is a multidisciplinary team meeting or discussion. So we have this in our department. We have radiologists. When required, we call rheumatologists. When required, we call pathologists. And then everybody, we all look at all the things. And finally, we say it is most likely to be this disorder or most likely not this disorder. More not IPF, IPF. So this is the final forum. So in other words, we are disadvantaged by the lack of a single test which will tell us whether it's IPF or not. Okay. Now, how do we treat? Once IPF is diagnosed, which means there's a lot of fibrosis, it is not going to respond to steroids. So what will happen if you give steroids? You will cause immunosuppression, you will increase the risk of infections and other steroid side effects, and the patient may die earlier. So steroids was the treatment 20 years ago. I have given a lot of steroids to patients. So looking back, we probably like made people die little earlier than they would have died without the treatment. Uh, so, so this decision is very important. The diagnostic decision of whether it's IPF or not IPF is very important. Now, if it is not IPF, then it is one of these things. NSIP or non-specific idiopathic, inflammatory
Not specific.
disease, desquamative interstitial disease, and respiratory bronchiolitis interstitial disease. So these are all disorders that are steroid responsive. It's not just fibrosis, but they actually have inflammation. So we give steroids, and then we also give azathioprine, cyclophosphamide, and these group of drugs because they reduce the dose of steroids. So treatment of IPF recommendation, what should not be given is what is called triple therapy. So this was done about 15 years ago, 10 to 15 years ago. We gave a combination of prednisolone, azathioprine, and N-acetylcysteine. So this should not be given. There is studies which show that the outcome actually is worse than placebo, which means if you give these combination of drugs, patients will die faster than if you don't do anything. Steroids, no. So once it is IPF, once you say that there is clear-cut established fibrosis and no inflammation, there is no steroids. N-acetylcysteine alone, no. So what should be given? Anti-gastroesophageal reflux treatment. So many patients have gastroesophageal reflux symptoms. So if they have symptoms, you have to actively look for it and treat it. Because this is known to worsen fibrosis, worsen symptoms. Vaccination. These people are prone for infections. So you should consider pneumococcal and flu vaccination. Oxygen therapy. When the lung fibrosis becomes significant, the oxygen levels will drop, and then you should consider oxygen therapy, and it can be given at home. It's long-term oxygen, not for a few hours in the hospital. So you have to get them to buy an oxygen concentrator and take this treatment at home. Then pulmonary rehabilitation. See, the lung is damaged, but the body works as a big unit. It works along with the heart, it works with the muscles, and all these put together make the person active and productive. So the rehabilitation increases muscle strength, it increases the cardiac function, and it overall improves the patient's total performance, even though the lung is damaged. So this is another treatment. All this should be given. In addition to this, now we have to treat everything with drugs. So let us look at drug therapy. There are some drugs which have come. Now we said that this is fibrosis. So lately, in the last 10 odd years, we have the antifibrotic drugs. The first among them is called pirfenidone. It reduces fibroblast proliferation. It inhibits TGF-beta stimulated collagen production. And, in NEJM, there's a categorical statement that pirfenidone slows disease progression in idiopathic pulmonary fibrosis. although fibrosis has already set in, it slows down the fibrosis. So this is a study. There are two major studies. They are called capacity 1 and 2. You know, all these studies, they have these attractive names. So capacity 1 and 2. So this is combination of both the studies looking at forced vital capacity. Now we said the lung becomes small. When the lung becomes small, the forced vital capacity becomes less. And so this study looked at what happens to the forced vital capacity if the drug is given here and the drug is not given, a placebo is given. So when placebo is given, the lung function drops. FVC drops like this. This is how it drops, a green line. On the other hand, when the drug was given, this is the drop. The lung function still dropped. There's no medicine to increase the lung function, but the drop slowed down considerably. So we can only slow down the decline of lung function. We cannot increase the lung function. So then they looked at a lot of endpoints. The forced vital capacity, which I showed you, all that is significantly improved in the people who are taking drugs. But another important outcome is this one. That is, now the lung function may change, but if the patient doesn't get better, he does not live more. What is the point? So these were secondary endpoints in these studies, and are they also better with the drug? It looks like all-cause mortality, which means whatever the cause of death is, they measured the people with the drug and without the drug and found that with the drug, the mortality was less. Treatment emergent all-cause mortality and IPF-related mortality, death due to the disease IPF, also was significantly less. So it is now clear that this drug slows down fibrosis and reduces the decline of lung function, and most importantly, it reduces mortality. Okay. Then nintedanib is a new drug, new kid in the block. In India, we have it for only the last 2 years or so. And only now it has become affordable. It was something like 60, 70,000 rupees per month. You can imagine how many patients can afford that. Now the costs have dropped and a lot more people are going to take this drug. This is a tyrosine kinase inhibitor, and it works against multiple growth factors. Again, we have to see what the studies show. The study is Impulses 1 and 2. These are again two short forms. And again, what did they show? The decline of lung function is slow when the drug is given as compared to placebo. In placebo, the lung function drops very quickly. Same thing with the second study. Both the studies showed the same thing with regard to lung function. But the secondary endpoints, they looked at exacerbation. You know, these patients not only have gradually worsening lung function and more breathlessness, but they have this acute flare-up of breathlessness. They may land in hospital suddenly getting severe breathlessness and severe hypoxia. They need oxygen and high-dose drugs, and often they end up in the intensive care unit and they don't do well when they have these exacerbations. So they showed that the time to exacerbation also is prolonged, which means they don't get exacerbation soon. They take more time to get exacerbation, which is also a very important endpoint because exacerbation means more death. Okay. So I have finished idiopathic pulmonary fibrosis. So do we have time for one or two more, or are we done? If we can stop here, I'm happy to stop and take questions because
no, sir, you can continue, sir. No, sir, you can continue.
Then I will talk about one. Yeah, I will talk about. Okay, let me see how it goes. Because interstitial lung disease, among 100, maybe 200 interstitial diseases, we have only covered the main one, which is idiopathic pulmonary fibrosis. I'm just going to touch upon the other common ones. You don't need to know everything, but you need to know the common things. So the common disorder, another one is called sarcoidosis. Let me give you, yeah. So sarcoidosis is a systemic disorder of unknown cause, and it has granulomatous inflammation, which means when we biopsy organs and examine it, there will be granulomas seen. The symptoms are dry cough and dyspnea. And the classic picture is hilar adenopathy, bilateral hilar adenopathy. So when you have an X-ray like this with this kind of bilateral hilar adenopathy, you should think of sarcoidosis. So the diagnosis is clinical, radiologic, and pathologic, which means you have to make a biopsy and confirm this. So usually we do lung biopsy through the bronchoscope. We go to the bronchoscope. I showed you that with the forceps, we took lung biopsy. And sometimes what we do is through the bronchoscope, these nodes are here. So we pierce the bronchus and come outside and pierce the nodes and take some biopsy. It's called EBUS. We use ultrasound through the bronchoscope to guide us to get this biopsy. There are some blood tests which can help in a rare situation. Angiotensin converter enzyme, or ACE, levels are elevated, and the PPD, which is a skin test, is usually negative in these patients, unlike just the opposite of tuberculosis. And the treatment in these patients is steroids. They are very steroid responsive. And so these are the relatively good interstitial lung diseases. They are more responsive to treatment. Pneumoconiosis. These are occupational disorders. Those who are exposed to sand kind of dust get silicosis, and those who are exposed to coal may get coal workers pneumoconiosis. And those who work with asbestos, especially these dust of asbestos, can get asbestosis. So these are just examples. And a good history is very, very important. The symptoms will be very similar. As I said, most of the symptoms are common, but it is this good history and the radiologic pattern of involvement and so on that helps us to clinch a diagnosis. And then the other important thing is something called hypersensitivity pneumonitis or extrinsic allergic alveolitis. These are caused by inhaled agents, and they can become progressive, severe, and even fatal end-stage lung disease. What are these things? That it can be organic dust. So the farmers may inhale certain organic molds, fungal particles, and so on, and that can cause, and it can happen in chemical industry due to inhalation of diisocyanates and organic acids. And it can also happen in the metal industry, people working with metals. But more important is indoor exposure to pet birds, in particular pigeons. So people with interstitial lung disease, you should ask not just occupational, but their pets. Do they have birds at home, especially pigeons at home? Then humidifiers. This humid thing allows certain fungi to grow, and that can cause interstitial lung disease. And whether their house has a lot of indoor molds and the walls, there's black colored molds. And if they are inhaling this every day, they could get this disease. So I have just given you a taste of the other disorders, but we have mostly covered idiopathic pulmonary fibrosis, or IPF. When people say ILD, they usually mean that. So I want to conclude. So to diagnose these disorders, you need a high index of suspicion. When people come with cough, with breathlessness, you think of asthma, you think of COPD, but you should also think of interstitial lung disease. X-ray is very important. When the X-ray shows these reticular patterns, then you should suspect interstitial lung disease. And when spirometric lung function test shows restriction, the lung, that FEC is reduced, then again you can think about it. And then the important thing is to order a high resolution CT scan. And this will be diagnostic. And after that, you know you are dealing with that disease. So when there's suspicion based on all these things, you have to get a HRCT done. Giving correct treatment is crucial. If you give steroids for people with established fibrosis like IPF, it will expedite their death. On the other hand, if you don't give steroids for people with sarcoidosis, hypersensitive pneumonitis, that will worsen their prognosis. So correct diagnosis becomes very important. And then you should think of this in the setting of difficult to control asthma. You keep on giving inhaled drugs for many years, patients are not doing well, and then you have to think about this and make sure you're not missing this. Same thing with rapidly progressive COPD. You should keep interstitial lung disease in mind. So I think with that, I am done. Thank you very much. Thanks for your patience.
Thank you, sir, for your outstanding presentation. At first, I like to hear from our today's chairperson about your presentation. As our chairperson expressed his fascination for this subject at the beginning of the lecture, so now I am offering Professor Syed Atikul Haq, sir, to comment about this presentation. If sir, if you want to add something, you can initially add, and then we have lots of questions. And our question answer section is flooded with questions. And also there are many questions in our live section. So now I'm offering Professor Syed Atikul Haq, sir. Then we'll go to question answer session.
Thank you very much. You have put me in a great, great trouble, I should say. Actually, it was a fantastic lecture. And Dr. Professor D.J. Christopher has removed many of the dilemmas. But, of course, ILD is a very big chapter. So to give a talk on ILD in details within, I should say, how much was the time constraint? He has given it for 45 minutes. So giving a lecture on ILD within 45 minutes is a great challenge. And naturally, he has selected a few topics for ILDs. And I think I would say he has very nicely presented. And I think the issues that are very important whenever our doctors come across patients with, for example, ILD, in most of the cases, the doctors do not differentiate between IPF, NSIP, or these things. So, and very commonly prescribe prednisolone or steroid. And today we have learned that, there are groups of ILDs in which steroids are useless. They don't help at all. And classically, this is IPF. In our case, in case of rheumatic conditions associated with ILD, we call it, UIP. He has already clarified that, when we know the cause, that is not IPF. When the cause is not known, then we call it IPF. And when the cause is known, like rheumatoid arthritis, systemic sclerosis, then idiopathic inflammatory myositis, or other rheumatic conditions, in that case, if the picture is like IPF with plenty of honeycombing, fibrosis, and no inflammation, for such cases we usually use the word UIP. And for this UIP, without evidence of inflammation at HRCT, sometimes bronchoalveolar lavage also gives clue to in presence of inflammation. If there is no feature of inflammation, or biopsy, if there is no evidence of inflammation, steroid or immunosuppressive drugs are useless. Rather, they can shorten the lifespan of the patient. That is very much important. So we have to remember, if we cannot treat the patient with drugs, we should not kill the patient. That is very much important. That is called, non-maleficence. The principle of non-maleficence is very important here, because every year we doctors are hastening the death, or shortly to say, we doctors are killing many patients with ILDs just because we don't distinguish between treatable and untreatable forms of ILDs. That is very important. Of course, in our practice, in fact, NSIP and organizing pneumonia is also common. These are more common forms. So in these conditions, immunosuppression definitely helps. And I would expect that, some from the audience will ask these questions, and Professor Christopher will be compelled to address these issues during the question and answer session. He could not include these issues within his lecture because of the time constraint, I well understand. So, and also another issue actually I want to learn from him regarding, that is called hypersensitivity pneumonitis. Actually, regarding interstitial lung disease, I team with, I should say misconceptions. I have a lot of misconceptions, I should agree. And I had an impression that we should call hypersensitivity pneumonitis or extrinsic allergic alveolitis when the cause is an organic dust or organic particle. But for heavy metals or metals, we call it, something like pneumoconiosis, but we don't call them hypersensitivity, pneumonitis. That maybe I am mistaken. That is one thing I need a clarification from Professor Christopher. And also, I have another misconception that, I think that the word ILD or DPLD is usually considered for, pulmonary restrictive pulmonary conditions or pulmonary parenchymal diseases with slow insidious onset and slow progression. Of course, there are a few exceptions like AIP, that is called acute interstitial pneumonia, or acute organizing pneumonia is also another with comparatively rapid onset and rapid progression. So except a few conditions, these are usually slowly progressive. But I wonder if among hypersensitivity pneumonitis, is there a subgroup with comparatively insidious onset and slow progression? That is also one thing I am interested to know. As a whole, his delivery was excellent, and the areas that he has touched, I have said that he has left untouched many issues. And if he decided to include all the issues related to ILD in these 45-minute lectures, we would have understood very little. So he have picked up a few issues, but he has clarified those few issues exceedingly nicely, exceptionally nicely. He has clarified those issues. So I thank Professor Christopher very much. I have put my questions also to him, and I think these questions will be asked by the audience, and I thank you all.
Thank you, sir. Already asked about this issue. So, Professor DJ Christopher, sir, if you start with hypersensitive pneumonitis and about query about DPLD by our chairperson, sir.
So, by and far, Professor is absolutely right that it is organic dust that is the cause of extrinsic allergic alveolitis or hypersensitivity pneumonitis. But there are certain chemicals which also initiate the same kind of immune reaction in the lung and cause the same pattern of involvement. That includes some heavy metal exposures. Chemical exposure, sorry. So heavy chemical exposure, that's what it means. It's not heavy metal, it's heavy chemical exposure. But the common culprits are these things, pet birds. Now, there is a theory about air coolers. I thought much about it and didn't mention it. But there is a theory that, perhaps that humid situation inside can cause fungi to grow, and then that can increase the chance of this. So if you have a air cooler, then make sure that it is periodically washed, allowed to dry fully, so that fungi cannot grow. Professor, have I addressed your questions, or is there anything I left?
Can hypersensitivity pneumonitis be, of insidious onset and slow progression like classic ILDs?
Yes. Insidious, yes, but usually it occurs over months. But if you look at IPFs, sometimes it presents over years. Patients have had 3 years of breathlessness sometimes. So this occurs usually over months, but the rapidity, it is very much like rheumatological disorders. There is a variation in the speed of things, but by and far they occur over months. So 3 months, 4 months, 2 months. That's the kind of typical duration of symptoms when patients come to us.
Okay, thank you.
Thank you, sir. And now we are going to start our question answer session. Our first question for Professor DJ Christopher, sir, by Dr. Mahmood Hassan. Sir, what is the age relation about ILD, and what are the common drugs that may cause ILD?
So there are so many drugs. So chemotherapeutic agents are by and far the most, best known. Bleomycin, and then drugs such as cyclophosphamide, methotrexate. These are all relatively common because they are commonly used. But the drugs that can cause is a very long list. I'll see if I can pull it up. It's a very long list, and so many drugs have rarely caused involvement. But I think the common, okay, let me try to. So the common ones are, so nitrofurantoin, we don't use it much, but when they used it, that was one of the causes. Then we have procainamide, isoniazid, oxygen. Oxygen, when it is used in high concentrations for a long time, can cause lung fibrosis. Radiation. So there are so many causes, but I would say that methotrexate, azathioprine, cyclophosphamide, busulfan, bleomycin are probably the drugs that we encounter more often in practice, because these are used now in these days more commonly than some of the other drugs.
Thank you, sir. Now I have a question for Professor Syed Atiqul Haq, sir. Sir, we know both rheumatoid arthritis and methotrexate. Both rheumatoid arthritis. Sir, question I'm asking again. Sir, both rheumatoid arthritis and MTX are known cause of ILD. How can we prevent ILD in rheumatoid arthritis patient taking methotrexate, or what precaution this patient should take?
Thank you very much. In fact, in the past, it was thought that methotrexate is a common cause of ILD in whatever patients maybe. But in a few recent long-term follow-up studies, it has been found that the incidence of ILD is not significantly higher in rheumatoid arthritis patients treated with methotrexate compared to rheumatoid arthritis patients treated with other agents. So nowadays it is thought that ILD caused by methotrexate is extremely rare, and for the treatment of for using methotrexate for the treatment of ILD for rheumatoid arthritis, we should not be at all concerned. It has got great benefit. It is still now. This is even after discovery of a good number of discovery and approval of a good number of biologics, methotrexate is still the first line treatment for rheumatoid arthritis, considering its efficacy, safety, as well as pharmacoeconomic viewpoint. So methotrexate is now, it is said that methotrexate rarely may cause acute alveolitis, but DPLD is very rare. And this is number one. Number two, in the past, we used to be afraid to use methotrexate in a rheumatoid arthritis patient with ILD, with an apprehension that methotrexate may worsen the pre-existing lung disease. Now, this is also, there are some studies that this is also not true. Moreover, methotrexate is found to be useful in the treatment of some forms of ILD, for example, sarcoid ILD. If a steroid is not enough, then, or if we need higher dose of steroid, long-term steroid, or more than 10 to 15 milligram of steroid for maintenance of remission, in that case, the use of methotrexate is rather encouraged for this. Moreover, there are some reports that methotrexate is useful in the methotrexate helps, also in the treatment of ILD associated with rheumatoid arthritis. So we can say, in fact, methotrexate, we should not be afraid of using methotrexate for ILD. That is number one. Number two, in patients, actually, in patients, those who have moderate to severe lung disease, we should look for alternative. We should not use methotrexate. We should rather use other things. And I think these are the only precautions that we can take. And of course,
Sir, another
in
question
patients
regarding
with
this.
CKD and hypoalbuminemia, the incidence of alveolitis is a bit higher. So if a patient becomes hypoalbuminemic or the creatinine increases, in that case also we should restrict the use of methotrexate. Okay, please continue.
Sir, another question regarding this, sir. Sir, how we can differentiate ILD of rheumatoid arthritis itself, or it's due to effect of MTX?
Actually, the same thing applies. When a rheumatoid arthritis patient develops ILD, we have to consider that this is due to rheumatoid arthritis and not due to methotrexate. But of course, I said that methotrexate may sometimes cause acute alveolitis, and in that case, the best thing is stop. We should stop methotrexate, and if the patient improves after stopping methotrexate, we may consider that methotrexate may be responsible. And for this, there is one scoring system is also there, and we can repeat this HRCT after 2 months. If HRCT clears after 2 months of stopping methotrexate, we can be tentatively sure that this was methotrexate-induced alveolitis. I say tentative because, there are other causes of acute alveolitis also. Suppose a patient of rheumatoid arthritis is getting, methotrexate. If he develops acute alveolitis, we cannot accuse solely this, this methotrexate, because these patients are also vulnerable to infections, and there are viral infections which may cause alveolitis. So infection is also a common mimic. So we cannot be sure, but we can guess that yes, this may be methotrexate-induced alveolitis, and in those patients, we should avoid using methotrexate in future.
Thank you, sir.
I would invite Professor Christopher to supplement my replies in this connection also.
I think you have put a very difficult problem very nicely. You have addressed it very nicely, I think. So the first point, in the interest of time, I'll make just two points. The first is that methotrexate is so valuable in rheumatoid arthritis. So we should never fear using the drug because the benefits are overwhelming. Now, if patient develops interstitial disease and you have fear about this, at that time you could consider withdrawing it and seeing whether that is making a dramatic response. So I think this is the two ways to look at it. Although there is no one correct response, but I think this is the best way to balance the two things.
Thank you.
Thank you, sir. Now, question from Dr. Jyoti Das to Professor DJ Christopher, sir. Sir, why clubbing occurs in interstitial lung disease? First question. And there is another question from Mahmudul Hassan. As general practitioner, should we treat interstitial lung disease? If so, then up to which extent we shall?
Okay, the first question, why clubbing happens, I think is, there are several theories of clubbing. Why it happens, and it doesn't happen only in interstitial disease, it happens in bronchiectasis, it happens in lung cancer. So suffice it to say, I think rather than go into that, which is a separate topic in itself, that if you have a patient with interstitial lung disease who has clubbing, the chance of them having idiopathic pulmonary fibrosis is high compared to some of the other things. So it really helps to put the overall pattern and picture together and make a diagnosis. I think that is enough to know. So in terms of whether general practitioner can manage, I would advise a lot of caution here, because even for us diagnosing interstitial lung disease, and anybody can diagnose interstitial lung disease. Well, not anybody, but uh, so you may be able to diagnose it, but to be able to differentiate the type of interstitial lung disease, to be able to distinguish fibrosing interstitial disease from the inflammatory interstitial lung disease, all this is very challenging. And then next, to give immunosuppressive drugs, to give steroids, to give antifibrotic drugs, it would be better off under someone with experience. It is the same scenario with rheumatologic disease. Can I treat rheumatoid arthritis? I definitely can use all those drugs, but will my treatment be as effective as Professor Atikul Haq? No, it won't be. It requires a certain experience. It requires a lot of balancing. There's no this. It's not like 5-day antibiotic course, BD for 5 days. Anybody can dispense. But treatment of these disorders is judiciously balanced based on clinical improvement, lung function improvement, radiologic improvement. And so this can be challenging at the general practice level. So I would say it requires a respiratory physician to treat interstitial lung disease. Having said that, they may come to you for follow-up. They may come to you in between with some infective exacerbation. You will be involved in this, but you will not be directing the overall course of treatment.
Thank you, sir. Now, questions for Professor Atikul Haq, sir. Sir, what is best screening test to diagnose ILD in our context? What are tests we should do while suspect ILD in Bangladesh in our context?
Okay, thank you very much. I think for this also, Professor Christopher is more competent for me. But even then, I can try. I would say that, for ILD, we should take a very careful history. That is very much important. And, particularly exertional shortness of breath and progressively increasing breathlessness. This is an important criterion, symptomatic, and then also dry cough is also another important point. And then we have to examine the patient, particularly for clubbing, and also bibasal Velcro crepes, as Professor Christopher has said. And if we get these things, then we have to go for high resolution CT scan. CT scan is very much important. And he has already made it clear that without CT scan, we should not proceed to treating ILDs. And also, in our, we are sometimes, in all patients, basically, in the next, we have to do spirometry with, that is, with DLCO. That is also very important as a baseline, to monitor the progression. And if we decide to treat the patient, to assess the effect of treatment also, these are important. So I think these are the things. But, we have to be very careful that, what is the cause of this ILD? As Professor Christopher has repeatedly re-emphasized, that it has got multiple causes. He said it has got approximately 200 causes or types. So we have to be sure what is the cause of this ILD. Sometimes, we may treat some chronic infective ILD also with immunosuppressive drugs and may hasten the process of death. So we have to be very sure that this treatment is the most appropriate treatment for this particular patient. And it's very much challenging. I don't dare to do this,
Thank you, sir. As a moderator, today I'm passing really tough time. So many questions. I'm really confused what to do, what not to do. The next question from Dr. Maksuda Akhi. She's a prominent dermatologist. Sir, her first question to Professor DJ Christopher, sir. Sir, what is the indication for surgical lung biopsy for patient in whom physician suspect interstitial lung disease? And another question for you, is there any role of plasmapheresis?
The second one, again, you have a lot of questions, so I'm going to be rapid fire answers. So plasmapheresis, no.
Yes, sir.
Okay. So with regard to when we do surgical lung biopsy, see, the diagnosis is based on the pattern of symptoms, pattern of physical findings, then the radiologic pattern, all put together, we make a diagnosis. So if we are not able to make a diagnosis and we are caught between, I don't know if it's a fibrosing lung disease versus inflammatory lung disease or cellular lung disease. That's what these are some terms that are used. When we are caught in that dilemma, that is the only time we think of lung biopsy. So if it is clearly ground glass shadows, which means it is inflammatory pathology, and if it is UIP, which is fibrosis, that is fibrosing pathology, both can be separated out usually on the basis of clinical features and radiology. When you cannot do it, the ones that come right in the middle and you don't know whether to go this way or that way, that's the only situation you do lung biopsy.
Thank you, sir. Her other two questions for Professor Syed Atikullah, sir. Sir, what is the prognosis of systemic sclerosis patient with ILD? Next one, what should be management in special condition like pregnancy with PSS and ILD?
Okay, thank you very much. In fact, the first question was, what is the, sorry.
Sir, what is the prognosis of systemic sclerosis patient with
Okay,
ILD?
Thank you very much. As a whole, prognosis of connective tissue disease associated ILDs is better than idiopathic forms. It has been observed that in patients with systemic sclerosis, it progresses to some extent and then stops. It doesn't progress anymore. That is one good thing. It is not relentlessly progressive in all patients. And then number two issue is that there is also a spontaneous resolution. Even without treatment, in some patients, it resolves. And also, actually for systemic sclerosis associated ILD, we follow certain characteristics for initiating treatment. Firstly, we have to say what is the percentage of ground glass. If the ground glass opacity is, occupies more than 20% of the lung fields, then we start immunosuppressive therapy. If it is less than 20%, we don't give it. And also DLCO. DLCO particularly, that is one alveolar distribution type. I forgot the exact word for this. If DLCO is reduced by more than 30% also, we start the treatment immediately. But if it is normal, or if it is not reduced by that percentage, then we follow up the patient. After 6 months, again we repeat HRCT, and then we also this spirometry with DLCO. If we find that there is progression of the condition, we start immunosuppressive therapy at that time. And actually, during pregnancy, we give steroid. And I have said that for systemic sclerosis associated ILD, the dose of steroid is smaller. I think the questioner knows that, systemic sclerosis, if we give steroid in high dose, it may increase the risk of scleroderma renal crisis. And that's why the dose for systemic sclerosis associated ILD, the dose of prednisolone is 10 milligram daily or 20 milligram every alternate day. In very aggressive cases, we use 0.5 milligram per kg, but not more than that. And this amount of prednisolone may be given in pregnancy also. That is, there is no bar. Regarding selection of the glucocorticoid sparing agents, azathioprine is again safe in pregnancy. We won't do cyclophosphamide. We have to avoid cyclophosphamide, mycophenolate, mofetil, these things. But the other option, azathioprine, can be safely given during pregnancy. If a patient with systemic sclerosis definitely requires immunosuppressive therapy, then azathioprine is a pregnancy-friendly glucocorticoid sparing immunosuppressive, and we can easily give it. So it is not that much difficult. Yeah.
Thank you, sir. Now our next question is for Professor DJ Christopher, sir. Sir, as this is COVID era, so we have some related questions about COVID also. Sir,
Okay,
first question, sir, what is the difference between...
Just I am requesting, Christopher, whenever you are giving answers to questions placed to you, if you find that, in my reply, there was some mistake, some error, or some incompleteness, you have, absolute liberty, because, I have agreed to chair this session just to learn from you.
Yeah, but all your responses, I had nothing to add because you did such a good job. That's why I didn't even bother to come in. You're doing a great job.
Okay, thank you so much. Thank you for this.
Sir, I'm personally feeling honored to be part with this great session with two living legend. Sir, next question. Sir, what is difference between fibrosis of COVID and fibrosis of ILD? First, can we give pirfenidine in COVID fibrosis? Second, last question, which is $1 million question. Sir, when you advise to do HRCT in a patient of COVID or suspected COVID? 3 questions.
Okay. So it's a very COVID-centered question, and I don't blame, is it a he or she, her or him, for asking this question? He, okay. So these are burning questions.
Also, our Professor Soid Atikullah sir has got, yes sir, burning questions.
Okay.
Difficult questions.
Okay. So, how is it different? So now, thankfully, COVID doesn't always cause fibrosis. Although there are radiologic shadows in a lot of people, more than 80% of the people will have radiologic abnormalities with COVID, even though they are sitting at home with normal oxygen. If you do a CT scan, you will pick up shadows on most of the patients. Even so, over weeks and months, by 3 months, most of the shadows have disappeared. So that is the good thing about COVID. Having said that, yesterday I gave a talk on post-COVID fibrosis. So people are encountering, and we are also encountering, people who are coming back with breathlessness, and then we find that they have lung fibrosis. It is in some ways, it can be one kind of interstitial lung disease. It behaves in similar ways. Now, how it is different? The IPF is a very basal predominant pathology, and this not necessarily is basal. So these are little different. So I don't think we will have difficulty in distinguishing them, because this will happen in the aftermath of COVID. So we may not have difficulty. Now the question about HRCT, when it should be done. In COVID patients, unless patients are acutely unwell, not responding to treatment, you suspect pulmonary thromboembolism, don't go on doing CT scans. Not many decisions are based on CT scan. Thromboembolism, yes. But the other decisions are not based on CT scan. They are based on hypoxia. They are based on the magnitude of symptoms and so on. So when do we check for resolution of COVID? So that is probably the hidden intent in that question. So definitely don't do CT scan for 3 months. If you really want to know about fibrosis, residual fibrosis, we should look at it only after 3 months. And that too, I think it's only in people who are symptomatic we should do. Since up to 3 months, they can have shadows and it is not abnormal. If they are if they are significantly symptomatic, as assessment of that, you will do CT scan. Not to look at whether COVID has cleared. So I hope I have answered the question.
Professor Sayyid Atiqul Haq, sir, do you want to add something? As all of we know, you have got very special interest on COVID.
Thank you very much. Actually, he has answered it completely, so I don't have anything to add. But I can ask one question to Professor Christopher. It is a supplementary question. Can we do CT scan in a patient who has symptoms suggestive of COVID-19, but both RT-PCR and antigen test are negative, so we could not confirm it? In that case, just for confirmation, can we do CT scan to see whether there is typical COVID pattern of, CT shadowing? Can it constitute one indication?
Yeah,
If
it
we
can
miss
constitute.
if we
If you
miss the
have
laboratory
done
diagnosis, laboratory confirmation.
correct, if you have done RT-PCR and it is negative, but you suspected very strongly it was COVID, you still suspect it is COVID, then there's no harm in doing a CT scan. It may substantiate your. Now, RT-PCR was not 100% sensitive. We have to understand that. So you can make a case for doing and then saying that based on this, COVID negative, but I'm going to isolate this patient. I'm going to treat this patient like COVID. So for that, you may use CT scan. But and it's interesting that you asked this question because they used it extensively in China. When the patient comes in, they push them into the CT room and did a CT first. The reason for that is different. Their PCR was not RT. Their PCR took several days, 3-5 days, sometimes 1 week to get the result. So they needed a quick test to, diagnose and triage them into the COVID areas. So they used CT scan a lot. But today our COVID tests come very quickly. We do 3 rounds of testing every day in CMC. So in hours, we get the results. And then today Gene Export is available, which will give you a report within 2 to 3 hours. So for the speed, we don't have to do, but when it is negative by RT-PCR and you still suspect COVID, I think there is a case to do it.
In our country, Professor Christopher, the one big problem is that, people, even including doctors, hesitate to go for testing. And, the test is actually, the positive in highest proportion of patients during the first 1 or 2 days, 2 to 3 days. After 5 days, it becomes negative in a proportion. After 7 days, even more. And the people goes for testing usually 5 to 7 days after the onset of symptoms, and thus, these tests become negative. That is also one common cause of, false negative RT-PCR in our country.
Yeah. Well, in our country also, patients now increasingly don't go for testing. They manage as long as possible. When they think things are not going well, then they come to the hospital. Yeah.
Sir, just another question, sir. Though it's not related to today's subject, sir, in India, are you taking hydroxychloroquine as prophylactic?
No, we don't take.
Okay,
now,
sir.
Chloroquine
Okay,
has
sir.
been proved
Sir,
to be not useful for treatment and also not useful for prophylaxis. So
I think
early in the pandemic, there was hope that chloroquine will work. But as the results of randomized control trials came out, we now know that COVID does not have any role in treatment of patients. And prophylaxis, as of now, there's no study to support it also in prophylaxis.
Thank you, sir. So now a scenario-based question to both of you. To Professor Atiq sir and Professor Christopher sir, a known case, limited systemic sclerosis patient with DPLD and pulmonary hypertension, become unplanned pregnant 12 weeks. Disease is inactive, now PSP 20 milligram with tadalafil, HRCT more than 30% lung involvement, currently treated with nifedipine, ecospin. My question, what will be advised the patient regarding pregnancy issues and treatment of DPLD now? At first, Professor Saidatik sir, then Professor DJ Christopher sir.
I think it's better to take the opinion of Christopher first,
I
and
think
then.
I will take your opinion because I would go very easy on the lung. I'll tell you why I think your treatment is more important here.
Okay, in that case, if it is, this ground loss opacities, if they occupy more than 30%, in that case, we have to treat, this ILD with prednisolone, depending upon her weight and aggressiveness of the overall condition. We can give either 10 milligram daily or 0.5 milligram per kg, and that is one thing for this ILD. For ILD, we can also start with azathioprine, starting with low dose, and gradually we can increase. For pregnancy, it is said that up to 2 milligram per kg is safe during pregnancy, so we can do that one. For actually, for this pulmonary arterial hypertension is associated with poor pregnancy outcomes. Actually, maternal death is very common in patients with pulmonary arterial hypertension. So if the pulmonary pressure is very high, say systolic pressure is more than 90 millimeter of mercury, in that case, it is advisable to terminate the pregnancy, because in that case, the mother's life becomes more important to us. But if it is less than that, and in that case, we have to use this tadalafil. We have to increase the dose of tadalafil at 6 weeks intervals. And also, if the pressure is not controlled, we have to add some phosphodiesterase, endothelin 1 receptor blocker like Embrisan. Embrisentan is the cheapest one in our country. We can use that one also.
Yeah, I completely agree with you. So if the lung involvement was not much less than what was said, we would have just allowed the pregnancy to complete and then acted. But if it is significant, I think the mother's outcome is more important. I would do exactly what Professor Atikul has said.
Thank you, sir. Sir, as all the good things has to come to an end, I will take last two questions. From Dr. Maisam Sobahan, his question is, sir, we see pirfenidone and nintedanib are two main drugs in the treatment of DPLD. How to start these drugs dose? Can these two drugs be given together? And how long we shall continue this two drug?
So both these drugs, as we speak, we have to now think that they are equally effective. There are no head-to-head studies comparing these two drugs. So which one is better? That there's no answer to that question. So you can take both. Now, pirfenidone, unfortunately, has a very high dose. Almost the minimum effective dose is something like 1,800 milligrams. So 200 milligram tablets.
We have to 3 tablets thrice daily.
Yes. And very often we go up to 2.4 grams. If they tolerate 1,800, we keep going, and even up to 2.4 grams. So it is not a very pleasurable thing to take in terms of the sheer quantity of tablet. In that sense, nintedanib has, I think it's 150 BD. So it's a smaller dose, easy to take, easy to handle in that sense. But both have their own side effects. The nintedanib has a lot of GI side effects, and pirfenidone has skin side effects more. It may also have GI side effects. In fact, we did one study, one of our postgraduates did as thesis. We found that the number one side effects in nintedanib also, in pirfenidone also was GI, not skin. We behave very differently from the Western population. So we don't have so much skin side effects with pirfenidone. Very, very few patients had skin side effects. Of course, we give them instructions to cover their skin, wear full sleeves, and so on. But only few patients have reported skin side effects. So you will also go by the tolerance of the drugs and take it. How long to take it? Well, I suppose as long as they live and as long as they can tolerate. So tolerance will become an important factor. If they're not tolerating and their quality of life is getting worse by taking the drug, they have to stop it. But if they are tolerating the drug and things are going well, we should keep continuing. There is no answer to what will happen in 4 years. We don't, or 5 years with nintedanib. With pirfenidone, there's a trial that has done 4 or 5 years follow up. But nintedanib, we don't know. So we have to keep continuing as long as things go well.
Okay, may I
So,
supplement or, actually, firstly, I would request the questioner, to be a bit more cautious about asking the question, because he said that pirfenidone is effective in ILDs. This statement is not wholly correct, because as Professor Christopher said, ILDs have got many types, and pirfenidone is effective in IPF, not in most of the other varieties. It is said that pirfenidone may also be used in some other forms of predominantly fibrotic form of ILDs, but not in predominantly inflammatory forms. That is one thing. So I am putting this caution just because I am sure that someone will catch his question and will start prescribing pirfenidone in all patients with ILD. So we cannot be non-selective. We have to be selective for
Really.
selecting pirfenidone and nintedanib. That is number one. Number two, pirfenidone and nintedanib, they are usually recommended for IPF, not for connective tissue disease associated ILDs. For connective tissue disease associated ILDs, the experience is more recent. Actually, there are a few publications of efficacy, reports of efficacy, which have been published very recently. So, and also they are found to be less effective than in IPF. In UIP, they are less effective. That is number two, you have to remember. So we should not be indiscriminate. In case of UIP, it is said that they are effective in mild to moderate restrictive lung disease, not in severely restrictive. For example, if the FVC is less than 50%, we should not use pirfenidone or nintedanib, because we know that this will not work. That is one, regarding our UIP, that connective tissue disease associated. And for connective tissue disease associated UIP, it is also said, of course, I would say, the audience, that, we have to remember that with connective tissue disease associated ILD, NSIP is more common. And there is also organizing pneumonia, or OP is also one of the common form. UIP is not the commonest form. That is one thing. But if we find that this patient has got definite UIP with HRCT, then we can give pirfenidone or nintedanib. And it is said that if FVC decreases by 10% or more at the end of 12 months, we should stop, considering that these drugs are not working. These are the three important points. And also there is one interesting report of enhanced efficacy with combination of pirfenidone plus nintedanib in rheumatoid arthritis associated ILD. But rheumatoid, I would say rather more exactly, rheumatoid arthritis associated UIP. Okay, and may I ask, at the end, may I ask one question to Professor Christopher Ehsan?
Of course.
Ehsan, do you allow me?
Sure, sir.
Moderator. Okay. Actually,
as you are chairperson, you have all the authority.
But of course, Professor Christopher, as you have also said that, in inflammatory forms of ILDs, your choice is also steroid, cyclophosphamide, and azathioprine. But I often see that, when our patients with ILDs go to CMC, they often come back with mycophenolate mofetil. It seems that, you have got a preference for mycophenolate mofetil to to azathioprine or cyclophosphamide. Can you explain me why?
Uh, our default is not mycophenolate, but we have in some patients we have used mycophenolate. Obviously, you know that it is more better tolerated and probably has lesser side effects.
Yeah.
But what I do not know is whether we have studies in mycophenolate in all the ILDs. So if we have used it in certain ILD, it means that in that ILD there is some evidence that it works. So when it works, it could be safer than cyclophosphamide. But if there's no evidence of use in that condition, we won't use it.
Yeah. Okay. Thank you very much.
Yeah.
Thank you very much, sir. Sir, last question for Professor Datikulak, sir.
Why? It is,
sir,
the speaker.
question from
the last question
Dr.
should be to the speaker, not to the chairperson. Okay.
No,
Okay.
sir,
Okay. No,
you
no,
know that our protocol, sir, you know, even DJ sir also knows, he also faced the same problem. We ask more question to our chairperson.
Okay. No problem. Please.
This is different platform, sir. Okay, sir, last question from Dr. Salauddin. His question is, sir, why ankylosing spondylitis cause upper lobe fibrosis while all other connective tissue disease affect lower lobe? Is there any drug dose relationship with fibrosis? And last, how much MTX or amiodarone is necessary to cause ILD?
In fact, for, as I have said, then for MTX, actually, this is now highly debated issue whether it causes ILD or not at all. That is one. So we cannot exactly say this. We can say that it is for in psoriasis patients or psoriatic arthritis patient. It is said that 5 gram, a cumulative dose of 5 gram is necessary for hepatic fibrosis. But for pulmonary fibrosis, I have not come across any such relation with dose, cumulative dose of methotrexate. And also regarding affection of upper lobe or apical segment in ankylosing spondylitis, I don't know the answer. If Professor Christopher knows, I think
I also don't know the answer. So we know that this disease have predilection for certain part of the lung.
Yeah,
but I don't think we know why that is the case.
Why in the upper lobe? Yeah. And what was the other third question? Isan?
So
what was the third question?
I just have to look, sir.
Okay.
Okay, sir. So another question which I has to ask to Professor DJ Christopher, sir, on public demand. So question is, if a patient develops diarrhea due to pirfenidone, can we continue it? But main part is that, what about use of pirfenidone in COVID?
Okay. I will take the second one in the interest of time. So people have hypothesized a few things about COVID lung fibrosis. So, this COVID lung fibrosis is even 6 months ago, pulmonologists and people have been talking about it. And we also were thinking about it. So we all knew that even if a small fraction of patients develop fibrosis, because of the huge number of COVID patients, this will become a substantial burden of chronic lung disease. So we have been watching this carefully. And so we have also been thinking, therefore, how do we treat these patients? And people have said that probably antifibrotic should be the way to go. Now, so that's where we stand. Now, as we speak, there are at least 4 or 5 trials, and we have also applied to do a trial comparing the role of antifibrotics in these patients, a randomized trial. So as we speak, there is not a single trial that has been published that shows that using this reduces fibrosis. We don't know when to start also, because people keep improving. We went through all these dilemmas. People keep improving up to 3 months. So at what point do you start? If you see lung shadows in 1 month and start, you will start on 50 to 60% of COVID patients. But isn't that an overkill when most of them will clear all shadows in 3 months? So as we speak, there is no evidence for use of any of these drugs on COVID patients.
So, Christopher, can we conclude that, we should not prescribe these drugs outside clinical trial? If there is a clinical trial with this, we can do, but outside clinical trials, we should not prescribe.
I think that will be good scientific practice. We cannot extrapolate the benefits we see with IPF into COVID. We cannot even do that to CTD-ILD. Now, it so happens that systemic sclerosis, there are studies. There are studies and probably rheumatoid also. And antifibrotics have some role, preliminary results. But antifibrotics are not used for pneumoconiosis. Antifibrotics are not used for pulmonary TB fibrosis.
Yeah.
Obviously, each fibrosis is different, and everything, one size doesn't fit all. So I would say that it is better to wait for evidence. And now, what can we give for these patients? We can give them rehabilitation that has been shown to be very effective. Rehabilitation and diet, and of course, if patients are hypoxic, we should give them oxygen. So all these are what we can give. But we cannot, as we speak, with evidence, prescribe antifibrotic.
Thank you, sir. Now we are almost come to an end. It's our first, as a speaker, it's your first presentation with us, Professor DJ Christopher, sir, and hope and wish that it will continue. Now, sir, do you want to give any conclusion speech or any conclusion remark about our today's presentation, about question, about participation? Then our chairperson will close the session.
Yeah, well, I didn't want to say anything, but I'm really very impressed by the interest and the amount of questions that came. And, I talk quite a bit. And by the quality of questions that come, you can see how involved the audience is. So I have a very positive sense of the audience and their comprehension of the lecture and the issues. So keep it up, BD physicians. You're doing well.
Thank you, sir. Basically, we could not take 1/3 of questions due to time constraint. Now it's the time to conclusion. On behalf of BD physicians and our sponsor company, SK Pharmaceuticals, we like to invite our chairperson, Professor Atikul Haq, sir, to conclude the session.
Okay, thank you very much. Today there is no vote of thanks from the sponsor, isn't it?
Yes, sir.
Okay, thank you very much. I would say that the session has been quite lively and very much useful to all of us. And I would rather suggest Professor Christopher, BD physicians to arrange another. Actually, in fact, our one great limitation is that, we have got very few respiratory physicians in the country. If we estimate, the need for, the respiratory physicians in our country, it must be at least 4,000. But in our country, possibly there is only up to 100 or maybe 150 respiratory physicians. So you can say, there is not enough experts for taking the whole burden of the entire population of ILDs in our country. So I think in our country, we have to empower our general practitioners and internists to treat ILD, at least, some less complicated forms of ILD. So a lecture on how to differentiate among different types, that will be not lecture, actually a workshop, because it will also comprise a few lectures, like, clinically, how can we differentiate, with history, how can we differentiate, with examination, how can we differentiate, with investigation, what should we do. So there are multiple segments. So if BD physicians can organize such a workshop on ILDs in future, that will focus only on diagnosis, not on treatment at all. It will not touch. And if individual practitioners like general practitioners or internists can eventually be empowered. The empowerment means delivery of knowledge. That is very much important. If some of them can be empowered, they can share the burden of respiratory physicians and can, can make the treatment more accessible to the patients. So I think you can, sometime you can arrange this. Of course, we have to, I mean, our GPs and internists will have to feel courage that yes, I can undertake. It's a matter of, it's a matter of great dilemma whether they will feel encouraged. That is important. So that is my one suggestion. And I would thank BD physicians for arranging this webinar. That was very important for me. I have also learned, and I am sure the most of the audience also learned a lot from Professor Christopher's lecture. And I also thank Escape for sponsoring this event. And finally, I thank Christopher for being very diligent in his work, for dedicating, for preparing his talk with utmost care, so that, with this talk, he may benefit the audience. That audience range from general practitioners to through internist and finally to respiratory physicians. I think there are some respiratory physicians also in the audience. And so I thank Professor Christopher from the core of my heart. And I feel really indebted to you. Thank you very much. And I hereby I close the webinar.
Thank you. Thank you.
Thank you, sir. Escape, please close the live. Just please close the live, then we can talk 1 or 2 minutes, then we shall leave. Live close, I say. Escape.
जी सर लाइव क्लोज
Okay, thank you. Sir, Christopher, sir, so which one is next from you?